I'll start. I think all of us, except the speaker, can put themselves on mute. And we've got a bit of material to cover, so I think we would like to start bang on time now. So good morning all. I'm Dr. SHANBHAG, consultant physiotherapist and deputy medical director at Physio Rehab. On behalf of our entire team, I'd like to welcome each and every one to this informative session about the scapula, the role of the scapula in shoulder pain. We at Physio Rehab, we believe in providing the best and the highest quality care to all our patients. And for that, the most important thing is our willingness and ability to learn and adapt to whatever new is going on. Hence, we have Dr. Nagraj Shetty, who is happily going to share some of his insights as a surgeon, from a surgeon's perspective, to shoulder pain. Dr. Nagraj Shetty is an eminent arthroscopic surgeon in Nanavati Hospital as well as Leelavati Hospital, but he has a widespread practice even in the suburbs. I think his practice goes from Virar to probably the tip of Mumbai. He and us, we share a very good professional relationship where I have seen him to be one of the few orthopedic surgeons who is happily ready to share information, to glean information, and also to impart information. Dr. Nagraj Shetty, would you like to start with a little bit of 2 bits before we start the session?
Sure. So thank you for the kind words, Dr. Shinee, and I share the same views about Physio Rehab, Dr. Shinee, Dr. Anjana, and we have had a very good professional relationship where we learn from each other, and that has benefited our patients over the years. And the idea of this meeting, when we had this discussion, was to share about one of the entities which is not very touched in both the physiotherapy world as well as the orthopedic world, and what we have learned over the years, and have an active discussion so that all of us gain from this. So I think with these words, we have planned it in such a way that Dr. Shinee will discuss the initial part. I will come in with the clinical part, and then Dr. Shinee will sum up again with some clinical data.
Have Dr. Anjana, founder Physio Rehab, with us. I can't see her anywhere. But ma'am, would you like to share some words before we start off?
Hello, good morning to everyone. Dr. Nagraj Shetty, it's a real honor for all of us to have you give us your insights on the scapula and its role for the upper quadrant. I also want to mention here that Dr. SHANBHAG has been an important member of the Physio Rehab team from its inception. She is a very keen teacher, loves to share her knowledge, and in a very unique style. And I'm sure you're going to enjoy today's session with Dr. Nagraj and Dr. SHANBHAG. All the best, and I'm sure we're going to have a Sunday morning well spent with both of you. Go ahead. Thank you.
Thanks, ma'am. That's very less pressure on me. Thank you. Okay, so we're going to start with some basic housekeeping rules. As usual, just the speaker will be on the unmute, and rest all, I really request everybody to go on the mute. We don't want the Sunday kitchen sounds coming in. I will be starting, as Dr. Nagraj said, with the basics of the kinematics of the scapula. We will take a break then. We will welcome all the questions. Questions preferably via chat. My colleague Meenal will be going through the questions and she'll be passing them on. Then Dr. Nagraj Shetty will be speaking from the surgeon's perspective, and then again breaking for questions for him. And then the last, we will be going for the movements and the muscular implications in various movement dysfunctions of the shoulder. In case we are not able to get to the questions, all of them, we have shared Dr. Nagraj Shetty's number and our information details also. Whoever has questions later on, you're most welcome to pass that on, and we will try our level best to answer it to the best of our abilities. All right, I think we will start. Just in the chat box, if you all can write, if you all can hear me, see me, and Dr. Nagraj also well. Okay, right, we'll start off. All right. The topic is scapular kinematics. Scapula is what we call loosely the shoulder blade when we are teaching our patients. And what we want to know about is the scapular kinematics, how it moves and what it affects. All right. Uh, this is a very cheeky slide. I had to insert it. We all know who this guy is, and he's become like the unlikely hero. And I think this guy is finally getting its due. Very talented chap. But I think Scapula is like that. Scapula, we have really ignored over the past few years. Thankfully, some of us are getting used to the idea that the scapula is the guy who is going to influence a lot of the upper limb movements. That's why I had to sneak this video, this slide in. All right. Dynamic stability of the scapula. Uh, when I say dynamic, it means that the scapula is used to and is has to control the movements of the entire upper limb. So controlled movements of the scapula is very, very important for the optimal upper limb function. The inability to control the scapula well is what causes a lot of the upper limb pathology and pain. We have to see that the scapula is not really very well. In this picture, we can see that this this area, scapulothoracic joint, it is not really connected via any bony connections to the thorax. So hence there's a lot of muscles involved over here to hold it. So that's why we keep saying that this has to have dynamic control. All right, so it depends upon a lot of active muscle control of the scapular muscles to keep the scapula on the thoracic joint. It is observed very widely now that a lot of the neck, shoulder, upper arm symptoms, all of them, they will be having something in common, which is a poor dynamic scapular control. That means in movement or in resting position, the scapula will be one problem area which will lead to a lot of problem areas of the neck, shoulder, and arm. And we'll go to see why. Here we have the scapula. It's one shoulder blade, but you can see over here that it has loads and loads of connections in terms of joints. Now, we know as a glenohumeral joint as the main guy. Okay, most of us are looking here, but look at where all it is connected. You have the scapulothoracic joint, that is what I just spoke about. You have the glenohumeral joint, you have the AC joint, you have the coracoclavicular joint, and then coming from here, you also have the sternoclavicular joint. So imagine you have the scapula not sitting in the right position. It can go and do a dysfunction here, 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 here itself. Hence, I think the scapula staying in position and moving well in position is going to be a very important thing for us. Coming to the big one, the role of the scapula. You have the scapula, which has to have stability as well as mobility, because the upper limb, it is extremely big in mobility. You know, the glenohumeral joint, the ball and socket, the socket is on the shallow side, the humerus can move. Hence, there's a huge amount of mobility we have, but the mobility gives way to stability. So the stability of the glenohumeral joint, the scapulothoracic joint, all that is the role of the scapula. The scapula acts as a base or the foundation for mostly all the muscles which are moving the glenohumeral joint. Now we know in our anatomy, the rotator cuff muscles, most of them start from the scapula itself. It provides optimal contact with the humeral head. This I'm going to talk a little bit in detail in the next slide. It lifts the acromion, that is, a full elevation is required for the overhead activities, and full upward rotation of the glenoid. It increases the mechanical stability by bringing the fossa straight under the head of the humerus. I think I'm going to just skip a few slides to just elaborate on that point. There. So only if your scapula will move well, will the glenoid come straight under the humerus to allow this movement. So imagine if you have a tardy scapula which is not moving at all and just staying somewhere here, this is not going to happen. Also, it needs to lift the acromion well. All right, and we all know what happens when the acromion does not lift well leads to issues of impingement, pain, and that is because of the biomechanical reasons that Dr. Nagraj will be covering a bit in detail later. I wanted to highlight the role of the scapula being a vital link in the kinetic chain. Now, what does kinetic chain mean? Kinetic chain is a movement chain. That means each and every muscle, when we are doing a particular activity, they are connected to the other muscles from the distal to the proximal. So say you have, I don't know how many of us are aware of something called the posterior oblique system, one of the most common systems. For example, the glute max of the left side would be connected, glute max of the left side would be connected to the right scapula. So when you have a thrower or a racket sport person doing this, the leg left, the glute max, latissimus dorsi, scapula, then the right arm, elbow, wrist. That's how it goes. Now the scapula is the main funneling agent. It is the main area from where the kinetic energy is transmitted from the proximal area to the distal area. Now suppose you do have any problem, I'll just skip to the next one. Yeah. Any problem in the scapula, so your kinetic energy transmission just reduces over there. So all the power that you generated when you are going to do that big jump to go here, that's all dissipated. Now, if a sports person is, let's say, a fast bowler, he has to throw the ball in the proper line and length, and it has to come with enough power. Now, suppose that power is dissipated somewhere near the scapula only and is not transmitting well. The hand, that is the shoulder, elbow, and wrist, has to do a lot of work to simply just pitch that ball in front. Now, it's statistically shown that a 20% decrease in kinetic energy transmission from the lower extremity to the upper extremity. It requires almost an 80% increase in muscle power and mass and 34% increase in the rotational velocity at the shoulder. And this is one of the biggest reasons why people have overload problems and injuries at the shoulder without any trauma at the shoulder also. So the scapula being so important that it is just one of the vital link in the kinetic chain, especially when we physios, whoever is looking at a lot of sports people, I think this is going to be a very important thing to consider from now on. Motions of the scapula, we are going to the movements, and first I'll be talking about the movement of the scapula itself, and then afterwards we'll be going and looking at the resting position of the scapula, the ideal, and what we can expect when the movement or when the position of the scapula is placed up, down, side. All right. So you have the scapula which translates in 3 planes and rotates in 3 planes. We are aware of that. The movements of the scapula is elevation, just up, depression, abduction, which we also call protraction, retraction. You have upward rotation and you have downward medial rotation. Now, these are slightly newer concepts which are coming in. I will take a little time explaining this. You have forward tilting. Forward tilting can also look like the inferior tip of the scapula jutting out. Okay, backward tilting. And I think we are all aware of the phenomenon of winging. Winging would mean the entire or most of the medial border jutting out. All right. So we shouldn't be confusing ourselves with forward tilting and winging. Slightly different things. Forward tilting, you will have only the inferior border coming out, and winging, you will have the almost the entire medial border jutting out from the thoracic wall. These are the movements. Okay. As I said, this is, I'm going to just making it a little simple. That's a superomedial border angle, inferior angle, because I'm going to speak a bit about this. So you have, this is elevation going up, depression going in, abduction or protraction, adduction. That's the medial border. That's the spine. We are going to speak a little bit about this in relation also. Now this is downward rotation. Downward rotation goes this way. Okay. Downward rotation is not to be confused with depression. This is going to be important. All right. Depression, the scapula has just merely gone down. In downward rotation, the scapula has rotated down. Okay. If we can see, the inferior border is more towards the midline or the thoracic spine. The AC is gone down like this over here. So if you can see the superior medial angle and the, one second, now I'm going to switch the video off so that we can just take it a little bit about the bandwidth. Yeah. So you have the AC joint, okay, acromion just below the superior medial border. All right, that's downward rotation. Downward rotation will also translate into a droopy shoulder. Please note this. But for that matter, even this translates into a droopy shoulder. So when we see a droopy shoulder, we cannot really for sure say that this is going to be downward or this is going to be depressed. They are two different things. All right, I'm taking a little while highlighting this because this is going to be a bit important when we are talking about the other points. Okay, right. Now, when we are seeing this, this is the exact opposite. That's just going upwards. All right, this is an upward rotated shoulder or a scapula where you have the AC higher than the superior medial border. But the inferior angle is away from the thoracic spine. All right. So these are the various resting positions. Now remember, I have made it very, very simple. Elevation, depression, abduction, protraction, downward and upward rotation. It is not necessarily going to be just one thing. It can be a combination of few things. All right. I will talk about the most common combinations that we see earlier, that we see in our practice. Right. You have the ideal scapular position. Y'all can just take 1 minute to go through this because I'm going to change the slide and I'm going to give you all the picture of this. All right, we have the ideal scapular resting position. Again, we have this point which we are talking about, which we have spoken about in detail earlier, this point, and now let's just start saying this, okay? Very easy things first, the landmarks, okay? You have the superior medial border almost going till the T2, has to be there. Then you have this one, inferior angle going till T7, that we all are clear. You have the medial border more or less parallel to the thoracic spine. Okay, that's the other thing. Then you have the scapula. We must remember that it is not going to sit in one coronal plane. It is not going to sit at that angle always. It is going to be slightly in front of the coronal plane. It is going to be at least 15 to 30 degree forward. Okay, more than 30 degree, we can think of it as protracted. Okay, and less than 15 degree, we can think of it as retracted. Now, true winging will be associated only if this whole red mark almost is going to be seen, or at least from here down. All right, we have the inferior angle here. Now, this thing, I purposely am taking this point last. The distance between the medial border of the scapula to the thoracic spine being about 2.5 to 3 inches. Now, research as we know it is changing. Sometimes it's written as 5 to 6 centimeters. Sometimes it's written more than that, depending upon the bulk of the person. So general rule of thumb, we can keep it as 5 to 6 centimeters. But what I generally like to do is I do a comparative between one side of the one scapula to the other. So I have a decent idea whether one side or the affected side is sitting too much protracted or retracted. And the other good point that we have to consider is that the acromion, okay, is going to be at par or higher than the superior angle. Okay, so key points. We just covered this, just reiterating. The superior medial corner is going to be along with T2. The acromion will be higher than the superior medial corner or at the level. The plane of the scapula is going to be 15 to 30 degree forward. The medial border is going to be in contact. This is one point I missed out earlier. Not only is it going to be parallel, but will be in contact. So it will be literally sticking to the thorax. The inferior angle is also in contact with the rib cage and it's not going to be tipping. So that means I had told you all earlier that the forward tilt position, this is the one which I'm talking about, and the inferior angle will be in line with the T7. Okay, I love this slide because this is what I keep telling everyone. The amount of muscles attached to the scapula is just a lot. Just 2 minutes to look at this slide, then I'll start with the explanations again. So, here are the scapular muscles, okay? And I'm going to start speaking about the significance of the muscles over here. Now, suppose you have a scapula which is elevated, okay? This way. Look at all the muscles which can cause it. We have not really paid attention to the muscles which start from the neck and go to the scapula, and now is the time we do that. The elevation of the scapula, that's a bit of a no-brainer. That is done by somebody called levator scapulae. I mean, the name of the muscle shows that. But what it does is not only picks it up like this, but actually picks it up in this way, in such a way that even this movement happens. All right, this movement. So it is not only picking the scapula up this way towards the midline, but also creating a bit of a downward rotation. So now we know that if the scapula is staying elevated, it is not necessarily just staying up in this plane, but it's also staying up in this way. All right, so we have this, that means the superior medial border is going to come up and the acromion is going to go down when you have an elevated scapula, and that is because of a dominance of a levator scapulae muscle. Also, a reduced counterbalance from, you guessed it, that is the lower trapezius, because if your lower trapezius is working well, it is going to take the scapula, instead of this way, it's going to take it, it's going to take it like this. So if you all can see, this movement and this movement are counteractive. So if you have decreased lower trapezius activity, it is going to allow the levator scapula to take it this way. All right. So this is what we commonly see. Elevated scapula is not necessarily going to mean that the trapezius is working well. Please look at the trapezius muscle. It's more or less transverse, the upper trapezius. So if the upper trapezius is working well, it's going to do this. That is in conjunction with the lower trapezius anyway. All right. So if we see a bundling of the muscle here, many of us will see it. When we tell our patients, those who don't have good scapular kinematics, to take the shoulder up, they will see a bundling of muscle here. That bundling is done by this one, levator scapulae. All right. I will talk about in a little bit of detail even later when the slides come in, but this is something which I want to highlight. When we look at the resting position of the scapula, what do we mean and what can we infer as to which muscles are working or working less? Adduction, okay, here, that's also simple. All right, look at this muscle, that's the rhomboids. Now, if we have an adduction, that means if we have this movement coming in, along with adduction, that is the scapula going to the medial border, not only will it go like this, but it will also go this way. So you have this one, levator and rhomboid, both pulling it inwards, but also going in for a downward rotation. Abduction, simple, the scapula going here, away. That is mostly done by a pec minor dominance, okay, because the pec minor is in front, and also because you have a reduced counterbalance from the trapezius, because the trapezius also is trying to get the scapula this way. You have the downward rotations. I'm just going to clear all of this as of now. The ink marks, yes, and restart it. Okay. Downward rotation is something which we all have to pay attention to. Downward rotation is going to be the acromion going down and the superior medial border coming up. All right. Now, downward rotation, we already know who causes it. A, levator. B, rhomboid. But also because lower trapezius, the one which is supposed to do this, and serratus anterior, the one which is supposed to do this, is inefficient. Now, who became inefficient first? Who became tight first? Bit of a chicken and egg situation. But many times it is proven that people who sit badly, that means sit in that poor forward hunched position for hours at end, which can be as simple as a person who sits at a desk job, has developed or does develop a lot of insufficiencies of these muscles. So if you have a dominant levator scapulae, a dominant rhomboid, an inefficient lower trapezius, an inefficient serratus anterior, then this forward droopy position along with the inferior tilt out, that is a forward tilt, which is the work of the pectoralis minor, that can lead to a downward rotated scapula. And this is going to be the big guy that we all have to deal with. And this is one of the most common clinical presentations that we see. True winging, that is the serratus anterior not working well. It's simple. It's very easy to see. It's almost like the medial border is just opening out like a window. We have a concept which we call as the inferior anterior glenoid. Inferior anterior glenoid. This downward rotation, inferior tipped out position of the scapula is generally associated with an inferior anterior glenoid. It's called IAG. I've just explained all of this. Okay, moving, we will take all the questions in the chat after I just finish my segment. Okay, I'm just going ahead so that we don't break the flow. You have the scapulothoracic humeral ideal movement. We've all learned this in our biomechanics. It has to be 2:1 or 3:2. Three distinct movements should occur. Glenohumeral, obviously, elevation. Upward rotation of the glenoid and the slight scapular elevation. Slight trunk movement is always there. Now, suppose you have a person doing a forward flexion. Beyond 160 degree, yes, the thoracic extension is going to happen. And obviously, we do not need any scapular winging. Now, I've highlighted this point of slight trunk movement because suppose you have a person who is fixed in thoracic kyphosis, or you have an elderly person, osteoporotic person, who has a lot of thoracic kyphosis, this person is going to have the affection or decreased mobility of the last 120 degree for sure. Last 20 degree for sure. So then if we are looking at a pathology or if you're looking at a problem shoulder, if you're looking at a problem shoulder of that elderly person and you see, oh, the range is just about 160, 150 degree, I think that would be okay, because the first thing you have to see is what is the range looking like on the other side. If the person is like this, I mean, all of us can just experiment right now. If we're all sitting this way, very rigid, and you try to take your hand up, it's going to get stuck here. For your hand up to go up completely, you need the thorax also to move out in full extension and neutral. So I think a good idea would be to first see what the shoulder range looks like on the other side, and then find out what should be the ideal goal of this side. Generally for elderly people with thoracic kyphosis as well as with osteoporosis, I do not expect more than 150, 160 degree, because the other side is also having that much. So generally when we get to that movement, it's good. And then we start working towards making that movement strong enough. Right. Most of us have been very, very particularly paying attention towards this joint, glenohumeral. But this picture is nice because it is showing us what all needs to move.
Somebody just said it's not audible.
I just got a message that I'm not audible. Am I audible, guys? Can someone just write in the chat, please?
Yes.
I'm assuming that's a yes, that I'm audible. Okay, I am going ahead. Right. What I want to highlight is not only does the scapula move, now this is a simple abduction movement, 180-degree abduction. Not only does the scapula have to move, but look at the other joints. Your SC has to do a joint, has to do a posterior rotation. Your SC joint also has to have an elevation. The glenohumeral joint also has to have an external rotation for this movement to be a good continuous movement. Now, remember when I spoke to you all about the downward rotated scapula? If your scapula started like this right from the beginning, okay, from here, it's not going to be able to fulfill this. Okay, and the trouble will start from there itself. So we want the scapula to sit in the right position, ideal position, to have good range of motions over here. Others, we're just going to land up with movement issues. I think I'm going to conclude here for my first part. Okay. And we'd like to take the questions if at all there are any. And let Dr. Nagraj start with his presentation about the clinical implications from the surgeon's perspective. I'm just going to take a minute to scroll through the chats if there are any questions. Do we have any questions here? Okay, I believe this is the all or none thing. Everybody understood everything or none? I think there is one question somewhere. Assessment, does it have to be in the static and dynamic? Yeah, there's a point given by Dr. Anjana. Assessment has to be in the static and dynamic. Yes, that's what I just said. So we need to look at the resting position of the scapula to begin with. And then obviously we have to go into the movement dynamics also, which I'll be covering in the next segment. I think, doctor, we'll be ready to go. We'll be ready to start with you. Probably by that time, people will wake up also.
Sure. So I've started sharing my screen. Can you see the first slide? Can you see the first slide?
Yes, doctor, we can see.
So I'll start with the presentation. So wonderful beginning to this topic by Dr. SHINEE. I think she very nicely talked about the relevant anatomy, the relevant biomechanics, and very lucidly she explained about the role of various muscles. Now, from the surgeon's perspective, scapula has been something which shoulder surgeons like me have been trained to understand from day one, but we still do not understand many aspects of it. And there are some things which we are clear about, and we are almost in sync with what points Dr. SHINEE mentioned. And my job is to tell you what are the clinical implications, what are the various ways these patients present to us, and how we differentiate them, and how in association with the physiotherapists, we try to get results for these patients. As Dr. SHINEE mentioned, I have a dedicated shoulder arthroscopy and knee and complex knee surgery practice, which is quite widespread, and I'm attached to these premier hospitals of Mumbai. When we talk about scapular dyskinesia, we normally should understand what do you mean by kinesis. By kinesis, we mean the normal scapular position, which is not only in the resting, but also in the dynamic motion, which is just what Dr. Anjana mentioned. So kinesis means the normal position of the scapula in rest and during motion. Whenever there is alteration in both rest or in dynamics or both, then it is called as dyskinesia. What you need to understand is that there might be a normal looking rhythm, but at rest also, if you see that the medial border is prominent, for example, you will have to call it as a dyskinetic scapula and have to work on it accordingly. Having understood the definition of kinesis and dyskinesis, this is one of the most important slides I want you to take home today. You need to understand that alteration of the scapulohumeral rhythm or dyskinesia of the scapula, it is maybe the primary problem. It might be part of an injury. It might be part of the primary issue, as in the scapula has led to pain around the shoulder, or it might be secondarily affected. So it might be the cause of shoulder trouble, or it might be the effect of shoulder trouble. And it's very important to understand which category your patient belongs to. So if you have a patient who's got a neurological problem, the serratus anterior, the long thoracic nerve is involved, obviously scapula is the primary problem and therefore the shoulder is getting affected. But more commonly, more often than not, we see that the scapula is secondarily affected due to various problems in the shoulder. And by shoulder, the take home today, as Dr. Shinee mentioned, need not necessarily mean a glenohumeral problem. It could be a acromioclavicular problem. It could be a clavicle problem. It could be a sternoclavicular problem, because shoulder is a 5 joint complex. So any of those problems are linked to each other and scapula can get secondarily affected. Now, this is a lady, this is a video which is quite old. It's important, especially for surgeons, for even if it's a female, you need to make sure you examine them from behind. You need to have adequate exposure. You cannot compromise on it. I think that's the take home message. You can never compromise on examination of the scapula, and you need to go from the back. When you ask this patient to move,
Very good. Get it down.
you can see that in a resting position also it's
Okay,
prominent,
keep doing it 4 to 5
and the
times.
rhythm is
Causing you pain?
completely altered.
Is it? Okay.
The medial border is prominent, the upper border is being pulled up, the prominence of the levator and the trapezius, as Dr. Shinee mentioned, is there. So it's an altered scapulothoracic rhythm, both in the resting position and in the dynamic position. This lady was being treated for shoulder pain by multiple surgeons, and nobody had really examined her back. Appropriate rehab did make the difference. So this is how I would like to start this presentation, as in you need to expose, you need to examine in the resting position for the medial border prominence, upper border prominence, and the rhythm of the scapula. Ask the patient to elevate the arm about 4 to 5 times and see the comparison to the other side, as you know what is the rhythm. So once again, medial border prominent and resting.
Very good. Get it down. Keep doing it 4 to 5. Is it causing you pain? Is it? Okay. Just 2 more times.
So we can clearly differentiate the kinesis on the normal side and the dyskinesis on the left side. And even simple elevation is causing her pain. So that is the importance of the scapula. It's the central pivot of the shoulder joint. And we need to make sure we examine it thoroughly and treat it accordingly. Now, as just taking the discussion of the previous motions data, another way of understanding this is that, this is a animation where you can see the scapulae being pulled by upward rotation or downward rotation. That is the red arrows. The green arrows are tilting it in anterior and posterior direction, and the blue arrows are for the internal external rotation. So these are the various motions. There are various ways you can understand them, but you need to understand that the scapula moves in a 3-dimensional manner. So it rotates, it tilts, it rotates up, down, and internally, externally. So that's the animation. So those are the red arrows, upward, downward rotation. Now the green arrows, anterior, posterior tilt, and the blue arrows, internal, external rotation. So if there is dyskinesia, and if you have a CT study where you have subtracted the rest of the body, you will observe that what happens if the scapula is not in rhythm. So this is the protracted scapula situation. The arrow is pointing towards the dyskinetic scapula. The opposite side is the normal one. And if you put the arm into motion, you need to see that the right side scapula is not retracting adequately compared to the left side. The left side is retracting adequately. We'll play this video again. So there's the right side not retracting adequately. The left side retracts adequately. So if the acromion remains in front, not retracted adequately in the elevated position, this anteriorly tilted acromion will cause impingement. And we will come to that in detail later, but adequate retraction not being there keeps the acromion in front, causing the impingement of the anterior structure. So the problem is at the back, but the pain is in the front. So The causes of dyskinesis, yes, mononeuropathies like the long thoracic nerve or the spinal accessory nerve. Long thoracic nerve, as we know, innervates the serratus anterior, the spinal accessory nerve, the other group of muscles in the back of the shoulder. But these affections are very, very rare. They are not so common, and therefore, in my clinical presentation that has come last, what we more often see is affections of the joints of the shoulder, that is the glenohumeral joint. So, if a patient has got a biceps or a labral injury, it could be primarily responsible to cause pain in the shoulder, therefore the scapula getting affected, or the scapular rhythm might have led to the biceps labrum injury. We will come to that. AC joint pathologies, either arthritis, which causes osteophyte formation, impingement of the cuff, pain, and therefore scapula getting affected, or AC joint dislocations, separations, or malunited clavicle fractures. So we see quite commonly that if a person has got more than 5 centimeter shortening of his clavicle because of a malunited clavicle fracture, there will be secondary affection of the scapula because the scapula starts getting protracted and the patient starts getting pain because of impingement. So this is what we see more commonly. And what we have to assess is the soft tissue component because that is responsible for about 60 to 70% problems. In the soft tissue problems, what we basically see is a combination. So we can call it muscle imbalances, like Dr. Shinee was trying to elucidate. There can be some muscles which are tight. The levatus are usually tight. The latissimus is usually tight. The pec minor is usually tight. All these trying to pull the scapula in a forward position and upward position so that the retractors, the serratus anterior, the rhomboids, are unable to maintain their retracted position, and then they finally give way, leading to severe weaknesses of these muscles. So muscle imbalance, so a tight group of muscles pulling it in various directions, weak group of muscles who are unable to resist this pull leads to this classic soft tissue problem. So this is how dyskinesis manifests. This is a nice image which talks about what I just mentioned. So what are the tight structures? The pectoralis minor in front. Now, pectoralis minor is a muscle in front of the shoulder, which inserts onto the medial border of the coracoid. And it's a small muscle, but having significant impact on the scapula because it pulls the scapula in front because of its insertional advantage to the coracoid. And this is very common in gym goers. They develop this tightness and secondary weakness of the retractors, that is the serratus and the rhomboids. A lot of them have upper trapezius and the levator scapulae tightness. Quite a few of them also have latissimus dorsi tightness. These tight structures lead to the altered rotation of the and the protraction of the scapula, leading to secondary weakness of the lower trapezius, the serratus anterior, the rhomboids. And as Dr. Shinee just touched upon, core weakness, hip muscle weakness also contributes to further worsening of this problem. So therefore, not just treat the scapular group of muscle, but the entire kinetic chain, and the core has to be strengthened in the rehab program. So this is what I meant to say, that soft tissue causation, soft tissue problems are responsible for more than 50% of the problems in most of the patients. This is a less common cause. That is, operative causes for dyskinesis are very less common. So imagine there is a cervical disc which is pressing upon the nerve roots, thereby affecting the long thoracic nerve, etc. This is also one of the ways the patient can present. Direct injury to the long thoracic nerve leading to the winging scapula. Forceful traumatic injury directly to the medial border of the scapula. Imagine falling down directly onto the scapula and having an avulsion of the rhomboids. That could be one of the causes. Snapping scapula. So whenever the patient elevates the arm, you can clearly feel a snap. You can feel a crepitus. You can feel tenderness on the spine, base of the spine of the scapula. That's classic of scapulothoracic bursitis. Sometimes there can be a prominent superior border pressing on the scapulothoracic bursa, causing inflammation of that bursa, leading to this sort of crepitus and snap. This usually does well with a steroid injection in that area. We evaluate them for a prominent superior border on CT scan, what is called as a Luschka's tubercle. Sometimes you see an osteoid osteoma there. These are the causes which are well treated by operative procedures, wherein we remove those bony impingements by what is called as endoscopic procedures. We can put a scope there and clean out that superior border, clean out that bursa, and the patient can have great relief. But here again, rehab is going to be critical in the full recovery of the patient. As I just mentioned, if there is an acromioclavicular joint separation, so the connection between the clavicle and the scapula is gone, the scapula will protract, and if the scapula is not strengthened, these patients are extremely symptomatic. Malunited clavicle fractures, sternoclavicular dislocations also can have secondary scapular pain. Obviously, some of these patients need operative intervention. So imagine a patient has got a labral injury. There is a labral tear with scapular dyskinesia. We put them on rehab, start working on their scapula. Simultaneously, we work on the mechanical problem. So we repair the labral tear, put them back on rehab for the full recovery. So this completes the operative intervention. Of this, what is most common is the intra-articular problems and the AC joint problems. These are the problems which we usually address through surgery, usually arthroscopically. This is a very extensive slide as to how you need to evaluate them, but basically you need to do a thorough biomechanical evaluation of the scapula from behind. You need to look at the resting position as to whether the medial border is prominent, the upward tilt has happened. You need to look at the individual group of muscles. So the levator, the trapezius, the rhomboid, the serratus, the latissimus, the pec minor in front. All these have to be evaluated thoroughly. Which are the tight muscles, which are the weak muscles. Then you need to evaluate the hip and the core muscles. And you need to see if there is any loss of voluntary control. Is there any sort of a habitual movement that the patient is having? Obviously, you need to evaluate from the front, from the acromioclavicular joint, clavicle, sternoclavicular joint. All of this you need to evaluate. And there are a couple of tests which we perform, which tell us that the problem is arising from the scapula. And that has been a game changer for me in understanding these patients. And I share a few videos for the same. So this is how you thoroughly evaluate the scapula. Now, this gentleman came to me with the pain in the front of the shoulder. He had already had an MRI done, and the MRI did show some edema, some swelling in the longer of the biceps groove. It did show some superior labral injury. It did show some subscapularis tendinosis, and he was advised surgery for the same. You can hear this gentleman talking about his pain now. So obviously our focus, and then he talks about pain in the behind. So this is very typical. They will talk about pain primarily in front, and then they will also mention that the pain is there on the medial border of the scapula. So unless you go at the back, you are going to miss the problem. And quite a few of these patients do get operated also with no relief. So this is his resting position. You can't really see much here, but if you see closely on the right hand side, the medial border is slightly jutted, slightly prominent. And what is important is this image. So if there is a tilt of the scapula, if the scapula is unable to keep itself retracted in motion and remains in a tilted position, it is the anterior tilt of this anterior acromion which impinges on the anterior structures. And there are three neighbors there. You have the anterior supraspinatus, which can get swollen, what is called as tendinosis. It can undergo partial tear and rarely complete tears. You have that is the first neighbor. The second neighbor is the longet of the biceps, which is in the vicinity, and it's a very dynamic structure which has got sympathetic innervation. So if there's any impingement on it, any swelling of it causes severe pain in the biceps groove and the intra-articular pain. And the subscapularis, which contributes to the cradle effect on the biceps. So the upper edge of the subscapularis provides the pulley or the cradle for the biceps. So this is what we call as a neighborhood syndrome. So what starts off as a minor tilt, minor biomechanical issue manifests in a very severe mechanical cause. And unless you identify it, you will end up over treating them without any relief. And with appropriate tips and tricks, you can really solve these patients' pain very well, most of the times conservatively. This is a very nice study which was published in one of the reputed shoulder journals. This is published by Professor Yonsik Yu, who is one of my mentors from South Korea. And they did a finite element model study. And they actually measured the pressure patterns on the biceps labrum junction when there is a 5-degree anterior scapular tilt. So as you can see here in the normal position, the pressure is about 30 millipascals. And when the tilt is happening about 5 degrees, you can see that there is a exponential increase of almost 5 times increased load on the biceps labrum junction. So if there is a scapular tilt, there will be biceps labrum junction. So a pre-existent tear will further increase. Absence of a tear, there will be a tear. So that is the importance of the scapula leading to biceps labrum junction problems. Importance of the scapula leading to anterior supraspinatus, longet of the biceps, and subscapularis problems. All problems which typically come in the front and in the lateral aspect of the shoulder where the patients pointed out. This was well touched by Dr. SHINEE, that if you have kyphosis, all of you can try. If you bend forward, you will not be able to elevate your arm to 180 degree. Unless you upright, you will not be able to elevate your arm 180 degree. And therefore, it's important to examine the normal side. as to what is the normal for the patient. Otherwise, you keep feeling he's stiff, whereas in reality, he's achieved his normal motion. Now, this is the same gentleman back again. I do this test for evaluation of the serratus anterior. So you ask the patient to push on the resistance of the surgeon's hand, of the examiner's hand, and with the tip of his shoulder. So his affected shoulder is the right side. If you see on the left side, I'm asking him to push on my hand and see what happens. He's able to nicely push me. I'm giving full resistance, and he's able to pull me forward. So he's a strong man. Let's see what happens on the right side. I can pull him and he will almost fall down. That is the kind of weakness. And when the patients actually see this feedback, it tells them, oh, this is something I never thought. I'm such a strong guy, and the doc could just pull me back. And that kind of weakness I have in my shoulder. And when we tell them that this is coming from the back of your shoulder, they then agree for this entire extensive rehab program. And this is the kind of feedback that they get. So this is the first examination that I do for the serratus anterior. The next thing is the scapular assistance test. So the scapula is protracted in front. It is unable to come to its resting position. So the examiner puts it back into the resistance position. The examiner assists the scapula to come back into the resting position, and then asks the patient to perform the same motions and ask the patient whether there was any relief after assisting him in his scapular position. So that's what the scapular assistance test basically does. You can also hold the scapula in the retracted position and ask the patient to take the arm up and down and ask if that pain has reduced a bit. So that's the scapular assistance test and the retraction test. And this is what we do. I am retracting the scapula, pushing on the inferior angle, depressing the scapula down.
Okay.
And then ask him to do the same motion again. You ask him to do about 5 repetitions and ask him to compare it to the pain that he had before this assistance.
In that area, did you see? Yeah, that's mild pain.
So that is what the patient then says, that the pain has become mild once you have assisted him. And that is exactly a feedback again, which tells the patient that he needs to work on these group of muscles, and whatever MRI findings or whatever pain he has in the front of the shoulder is related to problems at the back. A quick test about the core and the hip strength. It's called as the low row activation test. So in this, what you do is you activate your gluteus and your core group of muscles and then check for the scapular strength in terms of the retraction. So on the left-hand side, the examiner is about to check for the scapular strength, but on the right-hand side, you'll see the video. Without activation of the core, when the patient is asked to push on the examiner's hand in the backward position, they are weak. But when you ask them to activate their core and then now try to resist their backward position, they have the strength back. So never forget the core in the strengthening program. It's the key factor. Just do a single leg squat test. Some of these patients will have so-called Trendelenburg test positive. They'll have very weak hip abductors. Don't miss out on them. This is one such patient. So bad that they actually will fall down. So you'll keep working on the scapula, but the problem is also there in the core. I like this video, which is a slow motion of Rafael Nadal. And this gives you the idea of kinetic chain. See the power he generating from the ground, then into the ankle, knee, hip, spine, and then into the shoulder. That's basically the concept of kinetic chain. From the shoulder surgeon's perspective, this was well studied on baseball players, and therefore the various phases of throwing have been described as wind-up, stride, cocking phase, acceleration, deceleration, and follow through. So that's the concept of the kinetic chain. So you need to work on each group of muscles in the kinetic chain. The throwers are a unique population of patient. In order to get that power in abduction, external rotation, they are putting abnormal stresses on their shoulder and on the capsule and on the dynamic muscular structures. This is common in our country in bowlers, in badminton players. So in their dominant arm, they develop what is called as a internal impingement. I will just go through the details of this. Now, all these could be spoken together. Internal impingement, GIRD, meaning glenohumeral internal rotation deficit, and posterior capsular tightness, altered glenohumeral biomechanics. All these can be spoken together. Effectively, these patients present to you with pain, restricted motion, especially in abduction, internal rotation. So on the normal side, they can go all the way to the mid body or even beyond. On the affected side, they will just stop about 10 degree, 20 degrees. So that's called as internal rotation deficit. So this is one such patient. That's the normal internal rotation. On the affected side, you will see in the next videos that the internal rotation is affected. They will have some signs like labral tears, like tendinosis. They will have some subchondral cysts, etc. But the problem is more with the posterior capsular tightness. So that's the affected side. You can see it doesn't go all the way. So what happens in these throwers, because of their constant desire to get the power in abduction external rotation, they alter their biomechanics in such a way that the posterior capsule goes into a kind of a protective tightness. Once the posterior capsule of the shoulder goes into tightness, it secondarily affects the scapula. It pushes the humeral head slightly upward direction, which impinges the superior labrum between the humeral head and the superior glenoid. So the labrum starts getting pinched, starts getting damaged. Along with the labrum, if this problem persists, then the articular side of the supraspinatus also starts getting pinched. So this is the combination of internal impingement: posterior capsular tightness, superior labral injury, articular side supraspinatus injury, and sometimes even bony cysts. So this triad or quadrad is what you call as internal impingement, and scapula is secondarily affected in this problem. So that's the internal impingement concept. So posterior capsular tightness has pushed the humeral head above, pinching the labrum and the supraspinatus in the extremes of motion. And that is why these cricketers and fast bowlers have this problem, and they need to be surgically treated sometimes, along with a good rehab program, which focuses on stretching of the posterior capsule, glenohumeral internal rotation deficit correction, and scapular corrections. Some of these patients will have significant tears leading to posterior labral tears leading to posterior jerks. Here you need to examine if that is the posterior jerk.
It's more of a posterior inferior one. The minute
so the ball slips out of the socket and then it reduces back in that jerk. So you need to be careful whether these patients are having this problem involuntarily. Some of these patients will have an involuntary way of putting their shoulders out. These are not the kind of patients whom you operate upon. You need to do their biomechanical evaluation and correct their scapular rhythm. This is something, an entity which all of us know, the so-called impingement, which we all know, which is related to the curved acromion. Frankly, that entity is less common as compared to the biomechanical impingement. However, this gentleman is a classic example. He had come all the way from Rajasthan for severe shoulder pain. His MRI did show a near complete rotator cuff tear. He was referred to me by a very senior spine surgeon and saying that please operate on him as early as possible because he's in excruciating pain. Now, there was a disproportion in terms of his clinical examination vis-a-vis his MRI findings, which according to me was not responsible for his severe weakness. We got his thorough evaluation neurologically done. His neurology was fine. We got his MRI re-reported. The musculoskeletal radiologist also said, doc, this is about a 60-75% tear, which according to me cannot cause this sort of a clinical picture. So just look at him. He's excruciatingly painful, unable to elevate his arm. This is his picture. So he's got severe impingement, difficulty in elevating his arm. So I decided to do what is called as a NEERS test for him. So we injected his subacromial space with steroid, but we mixed it with a local anesthetic, hoping that if this is because of a severe subacromial bursitis secondary to impingement by the acromion, then with the reduction of the inflammation, the pain will subside and the patient will have some relief in pain. So this is about a, say, 10:30 in the morning video. We injected him. This is the minor OT where we injected his shoulder, and then we got him into the consultation chamber about after 15 minutes, and we'll see the video of the same. So quickly, subacromial impingement, all of us are aware, either because of a curved acromion, AC joint arthritis, lateral border of the acromion, etc., leading to severe subacromial bursitis and impingement pain. We all know about the hooked acromion, which is not so common as people perceive it to be. So this is the same gentleman after 15 minutes. And he's astonished by, including me, I was also astonished with this sort of a dramatic improvement. So this is a classic NEERS sign. Charlie Neer has really given shoulder surgeons around the world so many important signs which have helped us in our day-to-day practice. So that's the beauty of identifying where the pain is coming from. Quickly, another entity, the AC joint dislocation, which I talked about. If the scapula is stabilized properly, these can be well managed conservatively. So this is a gentleman who had a Rockwood type 4 AC joint dislocation. You can see the prominence of his clavicle on the right side. We put him on rehab, and this is his motion after about 2 months. So if you have a good scapula, even if it's a dislocated clavicle, it will just not trouble the patient. They will have full motions and excellent relief. So that's his scapula. We are working on it still, but definitely his rhythm is improving. And this is the serratus anterior testing. That's the left side. That's the normal side. And this is the affected side. It got good serratus anterior strength. So that's the beauty of stabilizing the scapula. Therefore, I'm putting the winging scapula last. This is a neurological entity, obviously, where there is a complete distortion of the scapular rhythm. The gentleman did have a neurological cause for the same. This is rare. It requires thorough neurological evaluation and different management altogether. And classically, winging scapular patient will have difficulty in elevating their arm about 90-100 degrees. They will have severe pain, severe difficulty. So that is something to be remembered. Take home message: scapular dyskinesia is either the cause primarily or effect, that is secondarily getting affected after most shoulder pathologies. Look for muscle imbalances, what is tight, what is weak, and work on the same. It is more common as compared to the neurological and the traumatic causes. Do a thorough scapulohumeral biomechanical evaluation and appropriate correction, which is the cornerstone for almost all shoulder problems. Thank you.
Thank you, Dr. Nagraj. That was very, very well explained along with the videos. Dr. Anjana would like to speak before we start with the next segment.
Yes, sure.
Hello. Firstly, Dr. Shetty, thank you so much for a very clear and a very simple way to explain to us about the shoulder kinematics, the dysfunctions that we see in our clinics, and how the physio and the surgeon together can work towards a better result for the patient. And I must say here, Dr. Nagraj Shetty is one of the very few orthopedic arthroscopic doctors who pay a lot of attention to a thorough evaluation and diagnosis of the patient. He gives a lot of value to the kinetic chain assessments. And I think we as the physios need to support our surgeons who are really counting on us to give conservative management a fair chance. It is so easy for a surgeon to recommend surgery, but Dr. Shetty is so thorough with his evaluation that he knows what is going to give value, whether his surgical skills, which are excellent and will give good results. But if the patient deserves to have conservative treatment, then I think he leaves it into the hands of the physios. And if we do not do a thorough job, a patient job for rehab, then I think we'll be disappointing the patients as well as the surgeon. So I think today between Dr. Nagraj and SHINEE, they have really given us such a lovely overview about the importance of scapula, the kinetic chain, and how we can all work together as a team. And I think today we have embarked on this journey with Dr. Nagraj, wherein we will in the future also engage in these kind of discussions and open our minds for better management opportunities for the patients and give better and faster results to them. So thank you, Dr. Nagraj. I think your videos and the explanation have really are going to help us physios in improving our results also. SHINEE, you can go ahead. Thank you very much.
Dr. Nagraj, we had some questions specific to you. I'd address the questions addressed to me later at the end of the presentation. I think you have one question saying that regarding the patient from Rajasthan, when you did the injection, the knees test, did you advise him for rehabilitation immediately after impairment?
These patients are usually painful. The immediate effect is not because of the steroid, it's because of the local anesthetic. So when the local anesthetic effect wears out, they can behave very differently. They can have pain for about 24-48 hours. So that is the only period that I allow some rest, but I ask them to get back to rehab as early as possible, usually within 24 hours. And the rehab is the cornerstone. Even in these patients where there is an external impingement, rehab is the cornerstone, because here it's the case of the secondary affection of the scapula. So we have just taken care of the pain such that the rehab can take over the scapular position and the impingement gets relieved. So to answer your question, as early as possible until we complete the rehabilitation program.
There was another question, and that was echoed by my question earlier also. You did mention about AC joint arthritis. We have seen in the MRs of very young people with early 20s, but they must be one thing I've seen in common with them is they're all heavy duty gym goers who do have AC joint arthritis written and actually seen and shown also. Would you care to elaborate on that, please?
Great question, and I'm happy that this was asked. Uh, AC joint arthritis is common in gym goers. So there are two varieties of AC joint arthritis. One is because of overload, and by overload, it's usually the bench pressers, the heavy push-ups, the heavy pull-ups kind of guys who develop this sort of overload. So AC joint arthritis starts off with narrowing of the joint space, sclerosis of the edges, and then there can be arthritic changes in the form of osteophytes, etc. More commonly, what we see is the early changes, and they come by early stage. They point out the pain at the point of the AC joint. Now, typically, these patients do well with a rehabilitation protocol. Again, these patients do have scapular affection. They do have pec minor tightness. They do have core issues. So when you address these issues, when you make sure the scapula is in back position, we have strengthened the group of muscles. We have made sure that the pressure on that overloaded position is relieved. So we tell them not to do cross-body adduction maneuvers. We tell them not to lie on the affected side. We tell them not to do hyper-abduction maneuvers. And we tell them not to do extension internal rotation maneuvers. So simple things like avoiding keeping the wallet in the back pocket, keep it in the front of the shoulder, and these other 4 points with anti-inflammatories gives relief. Sometimes for the early arthritis patients, we give an injection into the AC joint, again, just to temporarily relieve the pain so that the rehab picks up. This is usually done under ultrasound guidance or under C-arm guidance because it's a small joint and you cannot give it blindly. And rarely, now in my shoulder practice, which is since about 2007, AC joint surgery, what is called as a Mumford procedure, arthroscopic Mumford procedure, where we excise the lateral end of the clavicle, excellent gratifying procedure, but I might be doing it about say once or twice a year. So that's so rare it is for us to do this particular procedure. I hope I've answered the question.
Doctor, following your question about the AC joint arthritis and the corrections and probably modifications which need to be done when these people are doing the heavy duty front pushing kind of workouts, would it make sense, according to you, to let them know that such movements, whenever they are doing it, needs to be done very carefully, especially with the back portion of the shoulder being the hero over here rather than the front pushes? Or would you advise them to altogether change the kind of workouts they do very heavily in the gym?
Great question again. So I think it requires understanding of what are the expectations of the patient. First things first. Many times they keep doing the exercise without knowing why they want to do it. So there is a difference between a bodybuilder vis-a-vis a person who wants to stay fit. So, for example, when they are told that bench press is something that is which is causing you this trouble because you're overloading, make sure that you if you do not intend to build up these group of muscles beyond a point, try to avoid any heavy bench presses. Make sure there is a trainer at the back who keeps it supported in such a way that your elbow doesn't leave the body level. So maximum overload happens when your elbow crosses the body level, and many people don't know this. They start off from here and they take this extra load onto the AC joint to push it back. So you just need to come up to the body level and back. So your trainer supports the rod. He doesn't allow it to go beyond the point. So understanding the expectations of the gym goer, telling him to modify his activities, keep a trainer, make sure that it doesn't go beyond the body level. These are things, and of course, making him understand that typically you will develop anterior tightness. Gym goers are always crouched in front because of their anterior tightness, because they are concentrating on the cosmetic appearance in front. So the pec major, the pec minor, the latissimus, they're all always tight in them. So they have to understand that you need to do appropriate stretches. You need to have a good physiotherapist who can keep on doing the stretches for you. Keep concentrating on the back group of muscles also. So you need to do adequate amount of strengthening. So a good balance between the front and the back structures will make sure your AC joint is safe.
I'd like to highlight a little bit of what doctor has said is like we physios are the people who are many times in the junction between the person's rehabilitation and going back to the gym. I think a good thumb rule to give to these patients, suppose you have a typical gym goer who has got an injury, say doing a bench press or a chest press. Now we must remember in very simple terms, I'm going to divide those exercises into front and back. Okay, so whenever your weight comes towards you, they're going to work towards the back group. And back group, I would mean upper back right now. Whenever the weight goes away from you, it is going to work on the front group. All right. Most of our gymmers, because this is a very aesthetic group, will be working here. So when you want to return back to the gym, they ask you, right, how should I go back? What should I do? Now you have your RPEs, rate of perceived exertions. You have your RMs, repetition maximums. The idea would be first to tell them, start working on the back group first. Okay, so they have an idea as to this is where their body needs to be when you're doing even a chest press. A very good thing to tell them is from the joint here to the sternal bone here, keep this distance constant. So even when you're pushing off like this, you don't necessarily have to go here. This is where the maximum mess happens. Your AC joint starts getting irritated and all here. So even if you stay here and you do a good chest press or a good shoulder press, this does not need to happen. So very simple thing I tell my patients is, इधर से इधर का distance कम नहीं होना चाहिए. You pump this muscle up, I'm fine with this. इधर का इधर distance कम नहीं है, and I don't want your shoulder or the nape of your shoulder, nape of the neck reaching towards your ear. I'm taking this point because somebody had asked me that when you are having heavy duty weight lifters, you do have a good bulge of a muscle group over here. I want all of us to remember this, when you do this kind of movement, it is not really the upper trapezius which is coming in. Okay, it is the levator scapula. You will see the bunching over here, this one. The upper trapezius, when it has to work, it will work like this. That's it. Okay, because the upper trapezius, a nice trick to tell the patient is, think of taking the tip of the shoulder towards the nape. So it's just here. Because the fibers are like this. The levator scapulae fiber is this when it is sitting here. The upper trapezius is going laterally also. Obviously, it starts from here, goes lateral. So if you see some weightlifter doing this, he is going to fall in trouble very soon. Yes, you have an overall, you have a global muscle workup from here to here, and that's good. Then you know all the muscles are here. But a patient doing this, levator scapulae. A patient doing this and doing all the movements correctly, upper trapezius activation. So I think I've answered one of the questions which has come in before. I think, doctor, there were a few questions regarding the usage of steroids for patients with painful shoulder. When would you recommend? Do you recommend that faster so that the pain is controlled while doing rehab?
So great question. I think if a patient is indicated, if he has these sort of, let us say early AC joint, I'll tell you what are the indications first. Let us say there is early AC joint arthritis. I put them on a rehab program for about say 2 weeks, 3 weeks. If I don't see any satisfactory improvement, there is a very low threshold to give an injection. Long head of the biceps affections because of tenosynovitis, they have got this groove pain. Again, in the scenario of scapular dyskinesia, rehab, no relief. Within 2 weeks or so, I take the decision of injecting them ultrasound guided into the groove. Subacromial impingement, again, low threshold. So therefore, steroids are used very judiciously. I wouldn't say aggressively. It's not that they come and on the same day I have ever put a steroid on anybody. No, they will go through a trial. And if they don't succeed in the trial, then they get the injection. I have a low threshold for it. It's a safe approach if you go this way. About 1 to 2 injections are quite safe. The typical dosages are about 40 milligram or 80 milligram. These men are usually about 70-75 kilograms. It's a very small dose for just the local effect. We also try and use not long acting steroids, short acting steroids. So therefore, it works only until rehab picks up. It is not for a long term effect. It is not that the steroid is doing the job. Steroid is helping in relieving the pain, which is helping the rehab specialist in correcting the biomechanical problem. I hope I answered all the questions.
Thank you, doctor. I'll start with the rest of the presentation where we're just going to talk about the muscles involved, especially the scapula stabilizers in the role
Just,
of.
Dr. Shiny, just one point I would like you to answer this. Well, if you feel appropriate
Yes,
now,
yes,
or if you are going to present about it, you can talk about it later. Now,
yes.
in our shoulder world, we talk about pec minor a lot for the same category of patients who are the gym goers and the crouched posture guys. So, pec minor tightness is something we speak a lot about. And uh, if you could stress about, once you know the pec minor is tight in the form of tenderness here, the patient has, when you press on the pec minor on the medial part of the scapula, he's got tenderness. So, if you could elaborate how you approach these patients, have you ever felt that even after adequate manual corrections, this tightness hasn't gone away? This pain has persisted. I'm yet to operate on any such resistant pec minor tight patients, but there are surgical procedures to release these also. Can you elaborate what has been your approach towards these patients, now or later, whenever?
I, yeah, I think I'll talk about this right now only because when we are talking about movement, I'd like to talk about the other muscles. Now, pec minor, yes, it has got a lot of importance right now because we know that the forward tilt of the scapula is coming in because of that. But I'm happy to say that the pec minor is a muscle which is very pliable. It does work with you. You don't even need to have hardcore manual therapy movements. For all of us, just to understand, how do you know the pec minor is tight? From the back, you will see the tip mostly coming out. But from the front, say when you're lying down like this and you have this in front. So we know that the tip of the shoulder will be at least just say 1.5 inch or so from the floor. So if you have the capacity with command voluntarily for the patient to go behind over here, from here to here, voluntarily, that is, you are going to guide the shoulder down, or you're going to tell the patient, can you just try and touch the tip of the shoulder on the floor? This, if you can achieve, the pec minor is pliable. The pec minor is a muscle which is habitual in creating some movements here. So it is going to be the interplay of keeping the pec minor open and doing movements while the pec minor is open. So while doing its role, it has to support itself in the upper limb movement. So I have yet to see any patient where the pec minor does not stay open or remain open on voluntary control. Now, why I'm stressing on voluntary control so much is people just don't understand sometimes what it is to open this. For people to, when I say just try and touch the tip of the shoulder on the floor, they do a thoracic extension or a mid back extension. So what they do is end up doing this. Then I tell them, please increase the space between this and this, and then it goes backwards. So in my experience, just verbal strong cueing, tactile cueing works quite well in keeping the pec minor back. Now that is only step one, keeping the pec minor back. But keeping the pec minor back when you're doing movements, that's another ball game altogether, and that requires a lot of focus and concentration from the patient's point of view. So pec minor, I feel, is quite a pliable muscle, can be worked upon.
Okay, great. Thank you.
All right, we will start with the next part. Dr. Shetty in detail did speak about the impingement being a primary, it's a primarily a problem of the dynamic control of the scapula. I'm not going to go into details over here. This is a good picture of the serratus anterior. Now, serratus anterior, one more way of testing it is that you have the medial border over here stuck to the thoracic wall. And if suppose you've asked this person, suppose the left hand is the affected side, and if you ask this person to keep this position on itself, all right, and tell the person to just take this hand off, the person should still be able to maintain that medial border on the thoracic wall. So this is a good way to see if you have the serratus anterior capable of taking the position on even in a loaded position. So I'm just going to highlight quickly on the stabilizers of the shoulder, of the scapula. Obviously, there are many more, but these three are the ones which we as physios need to be very, very careful about and definitely ensure that they work well. Serratus anterior, we know the action is a powerful protractor, but is also equally important to keep the scapula in an upward rotated action. Now, Dr. Shetty did show us the scapular test. One more thing, what you can see is when you're doing this movement, the lateral border of the scapula should be coming to the mid-ax line. I think this can be better seen from the side position, but when you're doing this, just a simple forward movement. Now, Dr. Shetty told us how to check the strength. We also want to see if the scapula moves well with the serratus anterior's help. So the lateral border of the scapula will, when you're doing this movement, come till the mid-ax line. You can see it from the side. But obviously, when you're doing that, you want to avoid compensation. So if you see a bunching over here of the levator scapulae, or if you see the person doing a thoracic flexion instead of doing this, then you know that the serratus anterior is not having enough strength to go through motion. Now here I'm giving you all the tests how to do it with motion. So you have the lateral border of the scapula. It should glide nicely. The lateral border of the scapula should glide nicely on the axilla. Come till here at least while doing this movement. Now, if you see this movement, okay, that's moving here. But if you see somebody doing this, instead of just getting the shoulder in front, that's compensation. We also want to see who is compensating for a serratus anterior. If you see somebody doing this, that's again something else. All right. So serratus anterior needs to have good concentric muscle strength, but it also needs to have strength to go through and follow through the entire movement. I've just written down this benchmarks. Okay. You have the inferior angle when you're doing that movement, which should reach the posterior axillary line. The medial border of the scapula should be at least 8 to 10 centimeters away from the mid-thoracic spine. And these are the common and classic substitutions which we want to avoid. The scapular tilt, which happens quite often, elevation, all right, downward rotation, and this definitely happens, that is a spinal flexion. And along with that, you know, sometimes you will have a full truncal rotation, that the person's trunk will move instead of the scapula itself. You have the other big guys, the heroes, okay, the middle trapezius and the lower trapezius. This is a good slide I like to talk about. I think I did draw my diagrams for you all to just see the motions over here. So this is the UT upper trapezius movement over here, which is causing the upward rotation. You have the middle trapezius here, just simply taking the scapula towards the center. You have the lower trapezius, that is the action. So hence the UT, MT, LT, that is the upper and lower, middle and lower trapezius, doing the action of upward rotation, and that is being complemented by the serratus anterior. The serratus anterior and LT actually are contracting, okay? They have to do their functions together. If one does their function more than the other, it's still not going to work. But they're all a very good rhythmic movement, and that is your abduction, okay, along with the delt. I think that's the same picture. Okay, we had spoken in detail about the trapezius muscle, all right, and I had spoken to you all about this. So many people get confused between what the upper trapezius does and what the levator scapulae does. Upper trapezius alone does not elevate because mainly the fibers are all transverse. They are here, okay. Along with the middle fibers, it just lifts the lateral end of the scapula. Acromion comes up and it allows the upward rotation of the glenoid. The lower fibers will simply pull the superior medial border downwards. Okay, that means again it is going to upwardly rotate the glenoid. All right. Lower fibers will work at constant length at around 60 degree to maintain scapular stability at abduction at 90. So everybody is active to actually counteract the pull of the serratus anterior. Now, a very easy way to check what your middle trapezius is working as in motion, you ask the patient to lie down supine. Okay, the hand is out at the edge of the bed, and you simply ask the patient to just try and get the medial border closer to the thoracic spine. It's very simple. Prone lying, you're lying down like this, and you're simply taking it this way. The benchmark, now you want to see whether the middle trapezius is working enough and working till the full range of motion, is that it will come almost till about 5 centimeters or less than the thoracic spine, the medial border of the scapula. And obviously the same substitutions to avoid, not this, the scapula will not be elevated, it will not be retracted. Now remember, this is one thing which I wanted to bring into focus, that when we physios give the command of pinch the scapula together, okay, pinch the scapula together. Most of us, when we'll do it, we'll do this. If you can see, the retraction is happening, but also the elevation. So we're doing a rhomboid, a very pure rhomboid movement. I'm not saying that the rhomboids are not important. The rhomboids need to be there, but they don't need to be tight. They don't need to be overtired muscles. So what we want to do is also just tell people, place the scapula well. Instead of pinching the scapula, place the scapula is a better idea. And you will realize that when you're doing that, you will feel the middle trapezius work a little bit. The same other compensations, that if the person wants to do a middle trapezius, he might just rotate, he might just extend. So we want to avoid all these movements when you're testing the scapula. Lower trapezius is also another very easy test. Again, you're lying down supine, but your hand is coming up over here. Same command, that you want to try and get the medial border of the scapula, okay, close to the thoracic spine. The benchmark is about 2 to 4 centimeters of adduction, all right, and a lift from the bed of this part. So it's just going over here. Obviously, we don't want any adduction, that is no pinching of the scapula, no depression. Again, the same strategy, same substitutions to avoid, which is the scapular elevation, downward rotation. People might just abduct a lot instead of the scapula gliding back. No thoracic extension and thoracic rotation. So when we are doing our classic YW exercises, I think we should start staying away from this. This is not what we want to do, and we just want a subtle placement over here. Many times, until unless you have exposed the patient and you're not seeing and you're not placing your hand where your middle and lower trapezius should be, even the patient is not aware. But if the patient comes to know this movement, it's a very powerful, good movement, and the patient will say, okay, I'm feeling it exactly there. And guess what? My movement has become much more free. This is generally my face when I'm examining the scapula. Dr. Shetty made it very clear that the scapula has to be evaluated well. And I'm reiterating the fact now, because we have a bit of a time restraint over here. I'm going to talk about the movements in a basic forward flexion movement. All right. But for thorough evaluation of the scapula, you want to evaluate it in flexion, abduction, medial, lateral rotation, also in extension. I'm just going to quickly touch upon the brief substitutions that we see when we are doing the scapular movements. So what all can we see when we are doing a a shoulder movement? First thing, as I said earlier, that you can see an uncontrolled scapular elevation. I'm just going to start the video for that. Right. So uncontrolled scapular elevation, we know it is the levator scapula, just simply picking the shoulder up. And here, as I kept saying, that you will see the bunching. So that's the movement. Just observe this area. There. Okay. This is the bunching. Now, this is where the bunching has happened, and this is where the other shoulder is. You can see this. So it was levator scapulae which decided to do all the work. I think we can see it again. Okay, watch. It's all started bunching up again. So this is not going to be upper trapezius, guys. This is levator scapulae doing its work. And this guy has a decent range, not complete. And now when it came down till here, the levator scapulae decided, okay, fine, I don't need to work anymore. You have uncontrolled scapular downward rotation. And this is a very simple thing. You have to see whether the inferior border, now if it is downward rotation, the inferior border is going to be more closer to the thoracic spine. So if you have the scapula going like this, inferior border going towards the thoracic spine, you know it is a downward rotated shoulder, and downward rotated movement of the scapula. That inferior angle will not go towards the mid-ax line. Now, inferior angle is supposed to come till here when you're doing a full flexion. It's not going to reach here. It can indicate an inefficient serratus anterior. That's mainly the big thing. But also sometimes if we have the habit of telling the patient sit straight, but the command that we've given the patient is sit with your rhomboids all tight all the time, it's not going to allow that movement anyway. You have the forward tilt of the scapula, pectoralis minor, which we've spoken about. I hope to have the, yeah. So, you have,
the arms up from the front.
just watch what happens when it's coming down. Okay, this is also a medial border, but predominantly the tip of the shoulder coming out, tip of the scapula coming out. But what when we were getting a little confused as to how much of the serratus anterior is coming into play and how much of the pec minor is coming into play. But when we gave him a simple command of just staying over here, we also had to give a little bit of tactile cueing. When the patient did the shoulder up and down, he was much better off, and there was no medial border jutting out. There was just a bit of the inferior border jutting out, but the movement was much better after this. We also, for these patients, sometimes give a bit of a taping to give a little bit of proprioceptive input as to how the muscle needs to be placed. True winging, I think doctor has elaborated in detail. Again, it is rare, but we have seen it. There are some cases, obviously, which become surgical. That is, if the long thoracic nerve is affected. But with persistence, I have to use that word because it's not an easy thing to clear out. With persistence, we have managed to get the serratus anterior activated. Now, I have to highlight the fact that when we are talking about muscles like serratus anterior, middle trapezius, lower trapezius, these muscles cannot be seen. Okay, the patient can't see it. Now you have a bicep, you say, okay, do this and do that. But these muscles can be seen. So verbal commands, verbal cueing, understanding, communication of the therapist to the patient is going to be most important. So one easy thing is when we ask the patient to place his or own hand on the tip over here. So he knows that this is the tip which needs to be maintained over here when he's taking his hand up and down. Because otherwise it is going to be tough for the patient to understand what the patient is doing. And until unless you can cross that brain barrier, it becomes a little difficult for teaching the patient, because as we therapists, we take some time to understand what the movements look like and what this should be. So it is very difficult for the patients to understand it too. So patience, persistent, very, very good communication skills is going to be very important to train dyskinesias, especially when it comes to these muscles. This was the same winging. Yeah, I think this was the same. Yep. This person required a lot of verbal cueing to take care of his issue. Again, I like to sneak pictures in between. We are going to end our presentation with this, but what I wanted to say is picture abhi baki hai, because this is just a trailer of what we have discussed as to the role of scapula, the role of shoulder. Dr. Nagraj really highlighted the role of core muscles, the glutes, kinematics, kinetic chain. So if we want to really start treating our patients as a whole, just not look at the shoulder joint as being the problem area, and because it's the pathology area, we need to look at the entire chain, the entire movie, to take care of our patients in a better way. Thank you. We are open to questions. I'm just going to go to the chat box. Meenal, if you have just collated the questions, we'll be happy to answer. I'm going to stop the screen sharing.
We have a question again by Mitali asking how to stop the levator bundling. And another question by Venetia saying how to train the serratus.
I'll take the levator bundling first. First things first, let the patient know what is going on. Again, no. Right. Now, chicken and egg situation, I get this question a lot, whether we should release the levator scapulae first so that it gets out of the way and start building the other muscles. I like to do a joint approach. I like to actually start the work of the main guys, the serratus anterior, the middle and lower trapezius, the positioning first. Make sure the patient has understood it. I would release the levator scapulae. Okay, it's easy. The trigger points are very, very easily felt around here. And I would emphasize to the patient, listen, I have released one muscle. It is doing a job, albeit not a good job. Okay. And I also tell the patient that, your levator scapula is doing a bit of an overtime. It's doing OT. So it is a very crabby muscle. So let's just release that out. Get the serratus anterior, middle, lower trapezius, at least getting them recruited so that the levator scapulae does not feel that it has to do a lot of work. And remember one thing, levator scapulae is a muscle which can spoil the neck and the scapula. So it is a muscle which needs to get its due importance. Now, if you have a person who's sitting like this all the time, levator scapulae is active. So from here, taking care of the spine position, taking care of the shoulder, see the neck is already almost come into place. You release the levator scapulae at the same time, get the muscles, the stabilizers to work. I think that is a prudent approach. I hope I've answered that. How to strengthen serratus anterior? Various ways. First, get it to move in its entire range properly. You can also start with loading strategies. Even a simple thing like taking the other hand off while you're holding your serratus anterior in place. Good idea. And then starting to move the arm where it moves to full range with full command. That's a good starting point for strengthening the serratus anterior. Any more questions for Dr. Nagraj? I'm just going to quickly check the chat. I think, Dr. Nagraj, you spoke about the AC joint. That was one question coming in earlier. Steroids. Do some webinar on the scapular rehabilitation with kinetic chain. Yes, ma'am, it's a request. Yes, doctor, your next webinar is set.
I think they we want to know from you, not much from me.
I will. We are working with Dr. Nagraj to create a set of these informative webinars where there will be more of a practical approach also. Yes, that's in the pipeline. Keep your eyes peeled for that. I'm going to trouble Dr. Nagraj much more, that means. I think we are good to go.
Yes, I think we have covered all the aspects.
Okay. Thank you all for paying such good attention and being patient while we're going through the nuances of the scapula. Thank you. Thank you. I can't understand the name of the person who is writing the message. One second. One second.
There is a question from
Yeah. I think that's directed to you, doctor.
Yeah, when you give a timeline before giving the steroid injection, how much percentage betterment are we looking at? before deciding to continue the rehab or giving the injection. Okay. I think there is no objective data. There is nothing, no guidelines from the shoulder surgeon perspective. But effectively, what cannot work in about a 3 week of good rehab by a good rehab specialist like Dr. Shinee, for example. So if they do not get results in about say 3 weeks, they're not going to get it in about 6 weeks also. So that is why we have a very active discussion wherein we are informed about the baseline of the patient, and then we are informed about the gradual improvement of the patient. And it has happened quite a few occasions where Dr. Shinee, etc., have told, Doc, we are not getting any improvement, and therefore the patient is already consulted about it. So to answer your question, about 3 weeks, a 3 week period of good rehab should cause some improvement. Otherwise, we are immediately going to inject the patient in the conditions I mentioned.
Vismay had a question. With such patients is difficult. Oh, that was directed to me. With such patients, it's difficult to strengthen mid and lower trap with, yes. Vismay, your question is quite relevant because when we want to strengthen the mid and lower, these are the positions that we optimally want. We have to first see whether the other muscles, that is a very tight latissimus dorsi, a very tight pectoralis minor, they are not causing trouble in movement. As I said, it is a chicken and egg. So if you want to get to some muscles, first at least get to the proper resting positions. We need the resting position to come in, and we want at least movement to 90 degree to start something, 90 to 110. Now, we have a lot of tricks in our bag to get the muscles to start working or to the muscles to release. So I have seen when we deal with myofascial first and then capsular, it's much easier. So suppose you want to release a latissimus dorsi. You know the latissimus dorsi, when it is tight, it is not going to allow this movement. When the pec minor is tight, it is not going to allow this movement. So even in a resting position, whatever range of motion you have got, if you start activating the middle trapezius and lower trapezius, also the serratus anterior, at the same time opening the other muscles which are causing the restriction, we can start coming in. But I understand your question that if you cannot come till here, how will you start working in? What I showed you was the ideal movement through range of motion. You can obviously also start your activation even when your hand is down. It's simply a matter of getting that medial border closer without causing the substitutions. I hope I've answered your question there. Steroids work on physiology, but how steroids work on biomechanics of shoulder joint?
I think I'd like to reiterate that steroids will not work on biomechanics. Biomechanics can only be worked by the rehab specialist. But if the patient is in pain, whatever instructions you give them, they will be unable to follow them.
Yes.
Until you relieve their pain, which, as I told you, is initially by conservative treatment, so anti-inflammatories, cryotherapy, and rehab. Only if it fails and if the patient is so painful that he is unable to do the rehab, we inject them specifically into the local area where exactly the problem is, thereby giving you that window of a few weeks where the pain gets relieved and the rehab picks up. So steroid is judiciously used only for relieving the pain. It doesn't affect the biomechanics at all. So therefore, anybody who says I've given the steroid and have treated the problem is not correct. Therefore, giving the steroid on the first go, unless the patient is extremely painful, I mean, you know for sure this patient cannot go for rehab. That is obvious. Unless that is the case, we always rely on the biomechanical correction only.
I'd like to highlight what Dr. Nagraj has said, and something what we all should remember, that in pain, no muscle works well. We have to get the initial pain down with the surgeon's help, with the anti-inflammatories, with good sense, and even ergonomic advice, like don't sit like this, don't try to sit in a normal good position, try to correct the postures and sit. So in pain, it's a disservice to the patient. I mean, the patient is so much in pain. How are we ever going to sit and correct anything and correct the musculature? It's not going to happen. Biomechanics, when we say, come on, we also just discussed that the entire scapulothoracic joint is governed by muscle. So it is such a big playing area for the physios. Like, you fix this and most of your issues get better. But we also have to, bow down to nature a little bit, that if it is hurting so much, get the pain down. I think it will be a little problematic if we try and correct and do a lot of strength exercises, not recruitment. I mean, strengthening exercises when the patient is in pain. I mean, the patient is going to think that we are some sadistic people out there to try to get something. But getting pain down in a logical manner, I think, is the first thing which needs to be done. Getting function in is going to definitely follow when the pain goes down. Well, we have really not seen any chats from YouTube because I was not following that. Do you have any questions coming in from YouTube?
No, ma'am. Very similar question.
All right, I think we can conclude.
Yes, yes.
Doctor, a lot of requests coming in for a Q&A session. One more Sunday.
No, I think it has been summed up very well that ultimately these discussions help us to understand that it's a team approach, and at the center of the team is the patient. It's a happy patient, and that is going to help the entire community to grow. And the scapula is something which, even world around, there's constant research that is happening. There is constant updates that are happening, and each other's information and knowledge will help us in helping our patients better. So surely I think we can coordinate for more meetings on these lines. I would be happy to contribute from my side and continue learning, because that's the key for success in our professional careers. So thank you to Physio Rehab, Dr. Shinee, Dr. Anjana, and we will try and have another meeting. Thank you.
Thank you, Dr. Nagraj. It was very informative. Thank you all. I'd like to also thank my team members, especially Nishka, Kashmira, Meenal, who have been handling the logistics, because God knows I need a lot of help with that. Thank you all. We hope to come in soon with the continuation. If you all have further questions later on, Dr. Nagraj's number is there on, that's a number which will be open to for questions, right, Dr. Nagraj?
Yes, yes, yes.
Yes, it's there on the poster, and our addresses are here in case people want to, yeah, that's the one. All right. In case people want to pass in more questions, we'll be happy to answer and get back. Thank you all. It's been a good Sunday, well spent, and I think we all can go to enjoy the rest of the Sunday now. Thank you.
Thank you.